Good afternoon and welcome to today's IAC webinar, Technical Aspects of Imaging Patients with Suspected Cardiac Amyloidosis. My name is Kelly Baer and I am the Creative Design Manager with Marketing Communications at IAC. This webinar is a joint presentation of IAC and ASNC. And now I would like to introduce today's guest presenter, April Mann. Ms. Mann is the Chief Technical Officer at Martin Imaging in Destin, Florida. Serving on the IAC Nuclear PET Board of Directors representing CNMT, she is also an active member of the nuclear medicine and nuclear cardiology community. A true expert in the field, her works have been published in book chapters, continuing education, and research manuscripts, and she has given presentations on various topics in nuclear medicine, nuclear cardiology, management, and quality throughout her career, and we are happy to have her with us today. And with that said, I will now turn this webinar over to today's speaker, April Mann. April?
Thank you so much, Kelly, for that warm introduction. And thank you, ladies and gentlemen, for joining us this afternoon. Hopefully in the next 45 minutes or so, I will give you a better understanding into the technical aspects of imaging patients with suspected cardiac amyloidosis. This topic continues to be more learned every day as we go on, as new information comes into the field. So hopefully this will provide some up-to-date information and help you in your imaging labs get a better quality acquisition for your patients. Before we get started, just for disclosure's sake, I work for Martin Imaging Incorporated. However, this employment will not have any impact or effect on this presentation today. As we go through, hopefully I will be able to provide information about cardiac amyloidosis, just a little bit of background about how it starts, the differences, and how it affects our patient's heart. Most importantly, review the use of Technetium PYP for imaging of cardiac amyloidosis, describe the preparation and administration techniques, and then most importantly, describe some imaging acquisition parameters and processing parameters, as well as talk about some pitfalls we may run into during the imaging process that could affect our interpretation, and talk about some techniques to avoid this from happening. Cardiac amyloidosis is a process that creates a cardiomyopathy. The symptoms that patients present with is they generally, when it gets to end stage, patients are in heart failure. I want to take a minute to kind of just review the patient survival for different types of cardiomyopathy. When we look at this graph presented, and we graph out percent survival over 5, 10, and 15 years, when we look at idiopathic cardiomyopathy or cardiomyopathy due to ischemic heart disease, we can see that there's a slow downward trend. And as we know, if patients are intervened upon, we can extend their survival rate over 10 to 15 years, provided they get the right medical treatment as well as interventional therapies. When we look at cardiomyopathy due to infiltrative myocardial disease, mainly or types like cardiac amyloidosis, we see that this has a very, very steep mortality rate based and decrease in patient survival from early onset. And a lot of this, as I'll go through, has to do with the fact that there's still little that's known or is starting to come about this disease and how we treat it, and most importantly, diagnosis. So for knowledge sake, think about this as we're going through the presentation today. Cardiac amyloid is one of several varying causes of heart failure. As we know in cardiology, the standards that we see patients present in heart failure with are prolonged hypertension, arrhythmias due to structural issues, SVT, or other types of arrhythmias that patients can get. Most importantly, or most commonly in the nuclear cardiology labs, we see heart failure due to extended and prolonged coronary artery disease. But when a patient presents with just a cardiomyopathy with heart failure symptoms, this is where it gets to be a little tricky when they have no other risk factors or history for hypertension, arrhythmias, or coronary artery disease that we're used to seeing. One of the things we know is cardiac amyloidosis is a life-threatening infiltrative cardiomyopathy that commonly is a cause of heart failure, but it's characterized by extracellular deposition of what we call misfolded proteins, which form this amyloid fibril that deposits in the heart. This becomes important for us as technologists to understand so that we understand the disease that we're looking at when we're scanning our patients. Very similar to what we want to do when in our understanding of coronary artery disease when we're performing myocardial perfusion imaging. So as I mentioned, we know that cardiac amyloidosis is under-recognized and misdiagnosed. And some of that has to do with the lack of information that until recently we were not aware of in the field. Some of the common reasons for misdiagnosis are, most importantly, the fragmented knowledge itself about this disease. And then secondary to that is the misconceptions around diagnosis, how to diagnose, and what tests do we use for diagnosis. And in addition to the insufficient sensitivity of the test until recently, as we are starting to learn more and more about this disease process. And then the rarity of the disease process itself and how it presents in patients that we see come in with cardiomyopathies. The main types of cardiac amyloidosis are what we call immunoglobulin light chain amyloidosis, which is referred to AL amyloid, or transthyretin amyloid, which is commonly known as ATTR. Those two types account for about 95% of all cardiac amyloidosis diagnoses across the country. The other 5% fall into this category of types of serum amyloid that we consider more of a heavy chain fibrinogen. And this really gets into the distinctions within the disease processes itself. So let's talk about AL amyloidosis first. This is, as I said, the light chain, immunoglobulin light chain amyloidosis. We know that AL is a plasma cell dyscrasia. My knowledge of these words has become a little increased as I've been learning some of these new terms that we aren't used to seeing in nuclear cardiology. But essentially what happens is you get a monoclonal plasma cell overproduction of the immunoglobulin. And essentially this happens from the bone marrow, and you get the plasma cell that creates these light chain fragments, which kind of unfold or misfold to form these amyloid fibrils, which end up depositing in the myocardial tissue itself. One thing that we do and know about this disease is there is about 3,000 new cases per year that are presented in the United States. And we generally see this presented in those patients that are greater than 50 years of age. The unfortunate thing about AL amyloidosis is that we know the median survival of untreated patients is less than 6 months from the onset or the presentation of symptoms. And when we go back to that graph I showed about patient survival, the reason is because these disease processes progress, patients present in heart failure, and the time it takes to unravel what the diagnosis of the heart failure is, patient's disease has progressed severely. The second most common type is the transthyretin amyloid, or the ATTR. This type of amyloid is actually produced from the liver, where the transthyretin fibers become disassociated, creating again this misfolding and then refolding of the amyloid fibrils. This, again, if unrecognized and underdiagnosed, can be life-threatening and has a poorer prognosis the farther into the disease process that it is identified, or unfortunately a lot of times it is unidentified, and then patients are diagnosed at time of autopsy. And when we talk about the threaten or the ATTR, there are two main types of this type of cardiac amyloid. The first is considered a wild type or hereditary. The wild type, or the second is hereditary, or kind of what they call a mutant type. With this, the familiar hereditary genetic defects increase the chances of this type of amyloid disease. And this type of amyloid disease is known to affect peripheral nerves, the heart, the kidneys, skin, and the thyroid. Essentially, very similar to the wild type, however, a little bit more aggressive in other areas. When we kind of put this all together just to have an overall understanding of how this disease occurs, as I said, we get the deposition of the amyloid fibrils that deposit in the myocardium. It can be the AL type, which starts in the bone marrow, which is produced by plasma cell production, or the liver, which is the transthyretin or the TTR, which misfolds and creates the amyloid fibrils, both of which deposit themselves in the myocardium, leading to over time the cardiomyopathy. Looking at the two types, or the three types of cardiac amyloidosis, we know that, again, we have the light chain, the mutant, or the wild chain. When we look at average presentation of patients with the AL, patients are generally in the range of 30 to 75 years, but on average about 55 years of age. For the mutant or hereditary, generally we see this presented in patients that are about 50 years of age, but they've had documented ranges of 30 to 70 years of age. And then with the wild type, which generally a little bit more aged in our patients, so an average of 60 to 100 years of age. God bless those patients that make it that long. And then and our average age of diagnosis is 75 years. Interesting, when you look at cardiac amyloidosis, it is predominantly seen in males, with the AL being 60% of males will present. 80% of the mutant ATTR are males, and then interestingly, the wide chain is 95% of males. So the majority of these patients we see in cardiology are males, and with this wide chain. And generally, the majority of this type is deposited in cardiology, and that's where they see the formation of disease the most. So when we start talking about imaging, it's good to know the differences, because and as I'll show in a minute, when we see this wide, the cardiac uptake, generally we know that it is seen mostly in these wide chain or ATTR patients. When we look at the symptoms or presentation of cardiac amyloidosis, again, it's patients that mimic standard heart failure symptoms, and it's knowing the cause or understanding the cause of where that heart failure came from. So cardiac amyloid effects of the heart, it creates a stiff myocardium, which produces loss of myocardial contractility, which can then lead to heart rhythm abnormalities and decreases in blood flow. The symptoms that this creates is shortness of breath, irregular heartbeats, feet and ankle edema, weakness, fatigue, and nausea. So again, what we see are patients who have extensive coronary artery disease, heart failure, come in and present with. So it can be mimicked, or it can be missed to start with, unless there's known lack of other symptoms. As I mentioned, there are a variety of testing options, and as the field moves forward, trying to understand what testing options are better in what patient populations is finally starting to come to light. But some combination of all these tests we know now is very important to assist with not only the diagnosis of cardiac amyloidosis, but the type of amyloid will actually drive treatment, and then so understanding the type becomes extremely important. So testing options include blood work, ECG, biopsy, cardiac MR, echocardiography. What we'll be focusing on today is the technetium 99M pyrophosphate studies. There is also now work going on looking at different PET agents and the use of PET in the assistance and diagnosis of cardiac amyloid. This timeline was presented in Circulation Heart Failure Edition just as recently as last year. It was the expert consensus recommendations for the suspicion of diagnosis of trans-threatened cardiac amyloidosis. And this is where I was saying the type becomes important, because the diagnosis and treatment, as I'll show you in a minute, are a little different between the AL and the ATTR. So when we look at kind of appropriate time of testing at the bottom, and as it goes through disease progression, this diagram presents the timing in what tests are most appropriate. So generally, when we have a patient present with orthopedic manifestations, as we go through, we can see that doing a nuclear cardiology scintigraphy study becomes important in early diagnosis of the disease, and then looking at that in conjunction with other testing, cardiac MR, looking at biomarkers, and using echo in combination with clinical symptoms, all become part of the process. So with cardiac amyloid, it's not one test or another, it's timing of testing in progression of disease and when that becomes important. This is another algorithm that came from that same publication that looks at, again, recognizing symptoms of the ECG and echo biomarkers, what the results of all of those combined are. If one or more of those are abnormal, it generally means that the patient may be considered more of an AL type of candidate. So those patients tend to or should get referred for hematology and go on for biopsy. If there is a high clinical suspicion and all of those tests are normal, then this is when Technetium PYP becomes an important procedure if it's available. And as we go and look at the algorithm and we get into negative or positive, and then being able to differentiate true ATTR, and as I mentioned earlier, the ATTR is the disease process that we see most commonly on the PYP studies. And then being able to have genetic testing to determine whether or not this is a hereditary condition, or if it is not, if it's just this wild type that isn't related to genetics. And this algorithm was published by Dorbala and colleagues, which was from the expert consensus recommendations of multimodality imaging and cardiac amyloidosis, which was again just published in the Journal of Nuclear Cardiology in 2019. Both of these publications for reference are very good if you're looking to incorporate a program at your facility. This helps with understanding when the patient presents after the PYP study is performed, based on the grading, how or where does the patient fall. And the most important part of this that we like to stress is that you really want to look at the results of the PYP study in conjunction with the serum and urine and blood information to help decide if there's monoclonal proteins present, to help determine whether or not this is considered AL or ATTR, and how we kind of diagnose. So following this algorithm, having your physicians follow this algorithm along with interpretation can become very helpful to the referring physician in understanding where the patient's disease progression and type falls. Now let's get on to the most important part of this presentation, which has to do with imaging of our 99 MTC pyrophosphate studies. We know that 99-MTC was originally a radio tracer used in bone scans, and it was initially used in cardiology to quantify myocardial infarction due to its ability to localize calcium. Probably one of the first studies that I learned how to do as a student. We don't have to talk about how many years ago that was. The potential utility of this actually came to light in actually 1982. So this is something that has a long history, but again, not having up until recently, not having a good understanding of the disease, made it hard or unknown as a preferred test. But we know that even back then that there was 10 patients that were noted to have tissue-proven amyloidosis with findings suggestive on a study that was performed for myocardial infarction. So we know the significance of the uptake in the ATTR, and it's generally mild in the uptake of AL. The specificity and positive predictive value of 100% in absence of kind of the monoclonal plasma. So it's not, it's able to confirm a diagnosis of cardiac amyloidosis, but also it's able to differentiate between the AL and the ATTR types, which becomes, again, important for diagnosis. And I know most of you probably aren't doing this now. This is done in the pharmacy or most radio pharmacies, but good information to have if you are preparing kits. You want to let the vial come to room temperature for 5 minutes. You want to use 100 millicuries of technetium in about 4 mLs of saline to prepare your kit. And you want to just invert the vial several times, shaking it to kind of shaking it slightly for reconstitution, and then let it set for about 5 minutes before injecting your patients. Recommended imaging procedures or guidelines. This is a great reference for those of you who are looking to start this imaging or who have questions, is the ASNC cardiac amyloidosis practice points. It has nicely laid out what imaging characteristics should look like. So essentially, there is no prep for this procedure for our patients. It is a resting scan. Generally, patients should be given anywhere between 10 and 20 millicuries of the isotope. Recommended imaging is that you do both planar and SPECT at 1 hour, and depending on those findings, this recommendation was optimal 3-hour SPECT or planar as well. As we go through a little bit, one of the things as I present some of the kind of anomalies we see or some of the confusion around this, there are labs now and thought across the country that it may be better to actually skip the 1 hour and do just the 3-hour to avoid blood pooling. And I'll show you some examples of that. And most importantly, as we're talking about as doing regions of interest and some of the challenges with that, it is recommended, it is now thought that SPECT should always be performed, that this should not just be a planar study, but we will walk through that as well. So standard imaging procedure is that, as I said, that both planar and SPECT imaging should be obtained at 1 hour after injection. If there's persistent blood pool activity noted at 1 hour, delayed imaging should or may be obtained at 3 hours. Again, new thought processes is that imaging at 3 hours will help avoid that potential for misdiagnosis due to blood pool activity. The planar imaging is very useful for visual interpretation and quantitation of the disease. As we'll look at with the regions of interest and doing the ratios, those can be sometimes a little misleading. So having all of the information at your fingertips to be able to help our physicians make a diagnosis. And SPECT imaging is seen to be most useful to help avoid overlap of bone uptake, to distinguish blood pool activity from myocardial activity, for assessment of the distribution in individuals with positive planar studies, so to determine exactly where it is located, whether it is throughout the entire myocardium or just certain walls, and to help identify if there's any uptake in the intraventricular septum, and to help quantify the degree of myocardial uptake in comparison to rib uptake. So again, because you do have bone activity given this isotope, it is not you with the SPECT studies, you get a better comparison of myocardial activity compared to bone uptake to be able to present the whole picture. Some labs, we see this happening mostly in Europe right now, is whole body planar imaging can be helpful to identify if there's any uptake in the shoulders or hips. That can be a specific sign of ATTR being systemic rather than just isolated to the myocardium. And then a lot of questions we get about, can this be performed on our newer, the newer types of SPECT systems? And the answer is, if you have a solid state system or one of the newer non-traditional SPECT cameras, the best answer I can give you is there's lots of work going on right now with all the manufacturers. So before starting the process, make sure you work specifically with your vendor to understand their limitations and how their protocol should be specifically utilized with the newer systems. But with that systems. But with that said, lots of them now do have processes to be able to perform cardiac amyloid. So again, just work with your vendor to ensure that you are performing the appropriate procedure. To do the calculation of the ratio, it is important to be able to drew your contralateral lung region of interest and also your myocardial region of interest. And then what you do is you take the calculation of the mean counts for both, and that's how we come up with our ratio. For this particular patient, the ratio, as you can see, there is not a lot of visualization of myocardial activity compared to the rib and lung activity with a ratio of 1.05. This would be considered not suspicious for cardiac amyloid. But as I mentioned earlier, the regions of interest can be a little tricky in understanding and ensuring that, first and foremost, we're putting the region of interest in the right location. So the region of interest over the heart should be circular and be over the area of the myocardium where there is suspected activity. Our contralateral chest region of interest should be drawn on the right side of the chest, kind of in the outside of the sternum in the lung area, and you always want to avoid placing either of the region of interest over the sternum, ribs, or liver. And I'll show you an example in a minute of how just a little bit of misplacement can change the ratio. And this is why it becomes important to not just use the planar, the ratios, or the SPECT to make a determination, but to use all of the information that you have, and more importantly, going forward, why there's a thought process that the SPECT imaging is going to become more important as we go forward. So essentially, to do the region of interest, you take the mean region of interest from the heart and you divide it by the mean contralateral, and this will give you your suggested ratio of cardiac amyloid. Ratios of greater than 1.5 are considered to be suggestive of cardiac amyloidosis. So as I said, size and placement of the region of interest become very important. If we look at where the region of interest is placed here, it looks like it's down in the overlapping liver tissue. And this is giving us a ratio of 1.18. If we take this same patient and redraw our regions of interest, we can see that we now have a ratio of 1.5. So essentially moving the region of interest has now changed what we're seeing for a ratio. And again, this is one of the reasons why there's a thought that many labs now are using more of the SPECT information for a determination rather than just relying on the specific region of interest information. Moving on to doing our SPECT imaging, SPECT can be processed according to the patient's heart to contralateral lung ratios. For patients that have a ratio of less than 1.5, or there doesn't look like there's suspected cardiac involvement, it can be processed as a bone or chest SPECT. If the patient's ratio is greater than 1.5, then it can be processed as an MPI study. Most labs now have gone to just using the processing as an MPI study. The difficulty with this becomes if there's no cardiac activity, knowing where to do your reorientation. So again, it's understanding how the whole process works and then making a determination based on all of the information and what we see with our patients. From an interpretive point of view, and I know the next webinar will focus specifically on interpretation, so I'm just going to review this quickly, but the semi-quantitative visual grading is a grade 0, which means no uptake, through grade 3, which is uptake greater than rib uptake, and mid absence of rib uptake. So combining the grading with our SPECT imaging and our region of interest to make the best diagnosis we can for our patients. And again, if we look at figure 2, we can see the grading of 0 to 3, and then look at it in combination to the definitions of each one of those grades. Again, right out of the practice points, very good reference to learn more about how these should be interpreted and graded. And as I mentioned, just an example of doing whole body studies and how we can again use whole body studies from a grading purpose. This is an example of a negative only planar study. This region of interest was calculated out. It's probably very hard to see, but at 0.80. And when we look at the images, there is no visible myocardial uptake in comparison to the rib uptake. And when we look at the SPECT study, and in addition to SPECT being important, there is a thought that performing these with SPECT CT to have the SPECT, to have the CT as to be used as anatomical markers to help with the identification of location for myocardial activity, and also to help differentiate between myocardial blood pooling and myocardial uptake, as I'll show in a minute. So if we look at this image, the CT is on the top, the SPECT imaging is in the middle, and the fused images are on the bottom. And as we can see, there's no identifiable myocardial uptake in the SPECT images themselves compared to the bone or what is in landmarking, which is not involved in the myocardium at all. And looking at this at a bigger image, and when we look at the fused images, again, you can see where the myocardium falls based on the CT data, and that we see no discernible activity, PYP activity in the myocardium itself. Moving on now to a planar, this study is very positive. Without even, the region of interest was calculated at 1.83, but without even looking at the region of interest, the myocardial uptake is pretty visible. And then when we look at the processed SPECT studies, as we can see, there's complete myocardial involvement in all slices in all walls. And then we look at the SPECT CT fused images. Again, it's easy to see that the myocardial uptake is based on where the CT anatomical markers are, is right where we would expect it to be. And again, just looking at the images in a bigger fashion, all fused together. As I said, the straightforward cases like the one I just presented are very easy to determine when you have clean regions of interest. But what do you do with a patient that myocardium is now overlying, is under the sternum, and you have sternal uptake? How would we know in this particular case, it would be very difficult to get an accurate region of interest. So therefore, we really will need to rely more on our SPECT studies. And again, if there's focal rib uptake, for instance, if a patient has, broken ribs that they were unaware of, having that focal uptake could potentially skew your interpretation and your visualization and your region of interest if there is myocardial uptake. So being aware of these things, and again, using all the information you have, and not just relying on your regions of interest and your planar images to help make a diagnosis. And in this particular case, this region of interest was 1.31, and it looks like there is activity in the myocardium. But the question becomes, just looking at the planar, is this truly myocardial uptake, or is this prolonged blood pooling? And this is one of the specific reasons why this patient was scanned at an hour, why the thought is to, which becoming more common, is to wait the 3 hours and do your SPECT study at 3 hours to help to be able to differentiate between blood pooling and true myocardial uptake. So when we look at the SPECT and CT images of this, again, the CTs on the top, SPECT images in the middle, and the fused images on the bottom, you can start to see the activity. But again, when we look at this a little bit blown up, we can now see that based on the previous study I showed you that was positive, this activity we can now see looking at the fused CT images is definitely in the blood pool and not in the myocardium itself. So we know that finding on just the planar images was blood pooling and was causing the higher ratio. So really looking at how to do the differentiation between blood pool and is looking at the SPECT CT, looking at your myocardial uptake, and then looking at the blood, and then looking on the left and the blood pool uptake on the right. You can start to see the clear differences with having the CT and how we're able to determine whether or not this is true myocardial uptake versus just in the blood pool. So ensuring that we're allowing for adequate time for the blood pool to clear, and also having that SPECT information and SPECT CT information, if possible, really helps with a definitive diagnosis in these particular patients where it is not very clear or it's a little confusing. Now, finishing up, I just want to go through a few more cases. So this first case, that was a 93-year-old female, presented to the emergency room with increased shortness of breath and lower extremity edema. Her EKG showed a left bundle branch block, and it wasn't known if this was new or old. Her echo showed moderate LV dysfunction with moderate LVH with an ejection fraction of 32. Given the level of question with her, they went on and ordered a pyrophosphate study. In looking at her images, she ended up being negative. As we can see, this patient was scanned at an hour. There's nothing on the planar images that looks like blood pooling or myocardial activity, and our region of interest was 1.0. And when looking at the SPECT scans, this particular SPECT scan was processed as just like a general bone study. And again, as we look through the slices, there is no, what we can see is visualized myocardial uptake. And again, just looking at the images in a different color, there is nothing that looks visualized as myocardial uptake in this patient. Case 2, this is a 70-year-old male with a long history of atrial fibrillation. The patient had 2 ablations and was presented on sotalol and warfarin. Patient was having increased dyspnea and had an echo that revealed congestive heart failure with an EF of 45 to 50%. They did a cardiac MRI on this patient, and it showed diffuse myocardial enhancement consistent with an infiltrative disorder. And due to that, the patient was referred. Actually, this case was courtesy of Duke. They underwent a 99M technetium scan. Now, looking at this patient, again, very different than the first patient, you can see the visual myocardial uptake compared to the rest of the bone activity with a ratio of 2.10. And when we look at the MPI or the SPECT data, this was processed as an MPI because they did have the myocardial uptake to be able to focus on. We can see that there is definite myocardial uptake in this patient, and this patient was read as positive. And case number 3 is a 75-year-old male with a history of diastolic heart failure for the past 2 years, with noted swelling in his legs and arms, and also shortness of breath. The patient did have a history of peripheral neuropathy with numbness in fingers, and also had carpal tunnel. And as we mentioned earlier, the carpal tunnel becomes important because, again, we know that there is also that type of uptake in patients with cardiac amyloidosis. So understanding the whole picture. So this patient had a cardiac MRI that noted increased LVH, which was out of proportion with the mild hypertension that the patient was having. So given that there was a suspicion of cardiac amyloid, and again, images courtesy of Duke, this patient was referred for evaluation and management. And so the patient underwent a scan and a biopsy. Just the patient's ECG that that demonstrates his increased LVH. And again, when we look at the planar images, we can see diffuse myocardial uptake compared to the rest of the bones with a ratio of 1.66. And again, when we look at the process SPECT studies, we can see that there is definitely myocardial uptake in this patient, and this patient did have a positive biopsy. So again, looking at the difference between having a negative study with a low ratio processing as in a general nuclear medicine study compared to those patients that have suspected uptake, much easier to process as the MPI study versus the general bone study. So kind of in summary, I knew I threw a lot of information at you in a short period of time. It's understanding the disease process, understanding the difference between the symptoms with AL and the ATTR, and how those can present differently in the nuclear cardiology lab will help more streamline and result in better diagnosis of these patients who present for otherwise unknown cause of heart failure. We know that technetium 99M pyrophosphate imaging can play an important role in, especially in the non-invasive diagnosis of the ATTR type of cardiac amyloidosis. We also know that the size and placement of the region of interest is extremely critical and should not be the only method now used to determine a diagnosis of cardiac amyloidosis. SPECT imaging certainly allows for better evaluation of the differentiation between what is residual blood pool activity and what might truly be myocardial uptake. So ensuring that you are scanning long enough after injection to allow for appropriate blood pool clearance, then that is why now many labs are recommending that imaging happen at 3 hours, and that SPECT imaging is now becoming standard, not optional. So keeping those things in mind and using all of the information and not just using one piece of the information to help make a diagnosis for your patients. And it is important to note also, as I mentioned, based on the consensus papers, that it is very important and strongly suggested that the PYP scintigraphy imaging be interpreted in conjunction with the serum and urine studies to help exclude AL amyloidosis as opposed to ATTR to help the referring physician make a more accurate diagnosis and treatment for their patients. So with that, I'm going to thank you very much, and I think we will be able to open it up for questions.
Thank you very much, April. At this time, we will begin the Q&A session. From IAC, I'd like to introduce Maria Costello, IAC Director of Accreditation for Nuclear PET. She'll be assisting us with the Q&A session today. Maria, would you like to start us off?
Thank you, Kelly. So we did have quite a few questions that came through, and we'll get started. What are best practices to ensure that labs and amyloidosis imaging are ordered? This is a multi-part question, so I'll ask it all at once, but then I can ask separately too. Are labs using order panels? Do you need lab values when the physician reads the test, or can this be afterward?
So to answer that question, some of it depends on where the ordering is being driven from. So in talking to my colleagues at Harvard Healthcare, where I came from, their process now is that healthcare system has constructed a team, kind of a multidisciplinary team that has created order sets and kind of clinical pathways as to when they do the ordering. Lots of institutions that I've heard of now have a very specific panel. So I think to answer the question, where they were getting at is when a cardiac amyloid study or a PYP study is ordered for cardiac amyloid, there's an automatic lab panel in the electronic ordering system that gets ordered along with it. So the patients will automatically get both. So you're not depending on the referring physician to order both the imaging study as well as the labs. If you're not in a hospital, if you're in a private practice setting, I think it would be that same thing. It would just be ensuring that you have the standard labs that are ordered. Again, yes, it is part of a panel of what should be ordered for that patient in conjunction with that study. So Marie, did that make sense?
It did. So then basically you would need the lab values when the physician reads the test at the same time that they're interpreting it, or is it okay to have it afterward?
So I think it's most helpful if the interpreting physician has the lab values to look at while they're looking at the study, to help if they would like to include that in the interpretation of the study to help suggest whether it's the AL or the ATTR. Now, obviously that sometimes isn't going to be 100%, but I think it helps the referring physician. So I think having the interpreting physician have it the day of is most helpful.
Great. Okay, next question. Would you see heart uptake in bone scans if amyloidosis is suspected?
Yeah. I mean, I think if they're asking if you'll see the myocardial uptake, if it is suggestive of cardiac amyloid, then you will see it in the myocardium, but you will always see it in the bones because it is a bone agent that you're using.
Okay. It is suggested to do delayed 3-hour imaging and not, this is a clarification, it is suggested to do delayed 3-hour imaging and not imaging earlier. If so, do the ratio volumes change?
No, so the ratios will be the same regardless of whether you do it at 1 hour or 3 hours. Right now, the recommendations in the literature are 1 hour. If there's blood pooling, then do the 3 hour. What we're seeing as standard practice across the country now is more and more labs are skipping the 1 hour and going right to the 3 hour and just doing 3 hour and SPECT imaging as standard. So avoiding the 1 hour, doing a 3 hour planar with the region of interest and SPECT imaging to have all of the data combined together, and then using it to tell a story rather than just relying on the region of interest.
Okay, the next question, the PYP kit prep. Can we make the kit with less activity than the 100 millicuries per 4 ml? We use 1 vial per patient.
So I'm speaking specifically to package insert. So it's check with the manufacturer of the who makes the kit that you're using. Short answer is probably yes, it's probably fine. You could probably even use, 50 millicuries, but again, just double check with the manufacturer to make sure that you are preparing that kit appropriately. What I presented is just the standards in the literature for kit preparation of PYP.
Okay, should the regions of interest be on the same plane unless you needed to move them up due to liver involvement?
It not necessarily on the same plane, because if you have a heart that's sitting lower and a left lower lobe, then those would never be on the same plane. So it's really looking at the visualization and making sure that your contralateral region is truly in that lung kind of area away from the sternum and above the liver, and then ensuring that your myocardial region of interest is where the myocardium would be sitting. So being able to look at that anatomy and determining where those regions of interest should go, not necessarily locking it to they should be equal or one should be higher, one should be lower. It really is going to be different for every patient based on that patient's anatomy and where those kind of where the heart is located compared to where on the right side the liver and lung is located.
Okay, great. Next question. My clinic is performing only a 3-hour imaging set, but is calculating the ratio based on the 3-hour statistics. Is there a problem with this? Or can we use the 3-hour based on the 3-hour statics? Is there a problem with this? Or can we use the 3-hour statics to calculate the HCl ratio and grade by viewing?
Yeah, so it doesn't matter if you're doing the ratios at 1 hour or 3 hour. At 3 hours, so at 1 hour, you're going to have more counts, right? You're going to have more counts in the in the myocardium and kind of in the region of interest, and by decay, at 3 hours, the counts are going to decay, but it's not going to adjust the region of interest, the ratio, because the counts are going to decay equally. I think using the 3-hour becomes more important to help eliminate anything that would be blood pooling that could change that region of interest. So yes, it is perfectly acceptable to use the 3-hour ratios, provided that the regions of interest are in the appropriate, provided that the regions of interest are in the appropriate place. But yes, it's perfectly acceptable to use the 3-hour ratios. Okay. Did that make sense?
It did. Okay. So does the HCl ratio suggested for ATTR, you kind of answered this one already, but maybe we'll just repeat it. Does the HCl ratio suggested for ATTR change for the 3-hour delay images?
So no, again, it's the ratio itself between the two shouldn't change. Well, it'll change if at the 1 hour it was blood pooling. So if you're capturing on a 1 hour ratio blood pooling, and then you do it again at 3 hours, that ratio will change if the blood pooling, because the blood pooling is going to diminish. So knowing that can happen, and I think that's why a lot of labs are now moving away from the 1 hour and moving to the 3 hour to ensure that they're not running into, as that case that example I showed, as to not run into the blood pooling issue that could falsely elevate your ratio. So I think that's why, again, people are moving towards the 3 hour and away from the 1 hour to make sure there is no blood pooling.
Okay. Could one do an oblique with a caudal tilt if the heart is directly under the sternum to image the myocardium better for a planar view?
So you could certainly any change that you could do, right? So the suggestion for a planar is an anterior LAO and LPO. So you can certainly move the camera to get rid of that, but the suggestion on where to do the region of interest, because you need that contralateral lung, is on the anterior view. So you're always going to have an issue when the heart is sitting under the sternum doing your ratios. But to help differentiate, any views I think you can do to help differentiate where it's sitting is fine. You just don't want to do your regions of interest on it. And again, that will help with knowing, how intense the myocardium is, but then it's knowing the difference between myocardium and blood pooling. So I think, again, that's why the standard we're seeing is now becoming the SPECT imaging to help differentiate between blood pooling and true myocardial uptake. It's much harder, even with different views, to differentiate that on a planar study compared to a SPECT study. And because most places have SPECT capabilities, it just makes sense to do the SPECT imaging.
Okay. Do you recommend planar at 1 hour and SPECT only at 3 hours, or SPECT at 1 and 3 hours?
As I said, kind of the published recommendations are to do planar and SPECT at 1 hour, and then if there's blood pooling, to do both at 3 hours. But what I would say is I wouldn't do, if you're going to do a 1 hour and 3 hour, don't do one and then the other. If you're going to do the 1 hour and the 3 hour, do both. I think at this point that what we know is just the planar images are not enough to help with diagnosis. So you want to do, if you're going to do the 1 hour, do the 1 hour planar and the SPECT. And then if you're going to do the 3 hour, just do the SPECT or do the planar and the SPECT, but making sure that what you're comparing is apples to apples and not that you're comparing two different things.
Thank you. When drawing regions, is it necessary for the region around the myocardium to encompass the entire area of activity?
If you can without including other structures, then yes, but you want to be cautious about making sure you're not including close to the sternum or if at all possible. So making sure that the regions of interest are consistent, but only including myocardium.
Okay. Have you had the opportunity to do amyloid scans on a dedicated cardiac camera? Just wondering what your experience was, SPECT workaround. I think they're asking, like, some of the dedicated cardiac cameras, they can't do planar, so would it be okay?
The fixed
yeah.
So in that case, the answer is right. So in that case, the answer is yes, because you're not going to do the planar images. You won't be able to do. There's been some suggestion that you can do a region of interest off what is the anterior view of the SPECT study. Right, if you were to pull that projection out, just knowing that you're going to have a limited amount of counts. But given that, more and more, I think physicians are suggesting that SPECT become the standard. I think then that, if that's where the recommendations are moving towards, then I think that is perfectly acceptable. As we've seen, you are fully able to differentiate between blood pool and actual, activity with SPECT, and SPECT is becoming the recommendation. So I personally have not scanned patients, but what I'm hearing in the field is that's kind of what's happening. And again, as I said, there a lot of the manufacturers who have put out these systems have worked with thought leaders in the field to come up with protocols to be able to do this procedure on those types of equipment. So working with your manufacturers and getting them in touch with somebody who is doing this procedure routinely can help with suggestions on how to move forward with that. But I think if you're just doing SPECT, I think given that there are some labs that's where they're moving, I think that is perfectly acceptable.
Okay, thank you, April. That was a great presentation. That's all the time we have for the questions. And so this concludes it.
Okay. Thank you very much, Maria, and thank you, everyone. And a very special thank you to April Mann for this presentation today. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of this live session. and also be available from the IAC webinar portal for 3 business days. On the left side of the My Account page, you'll click on Webinars. Look for the title of this session, Technical Aspects of Imaging Patients with Suspected Cardiac Amyloidosis. Beneath this title, you will click Review Event. On the left, select the Evaluation tab, then click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen, and anytime thereafter through the CE transcript section on the My Account page. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.